Bismillahirrahmanirrahim. Let's see the abnormal uterine bleeding. So you know better the every reproductive age female undergo a normal uterine bleeding period. Okay, that's a menstrual cycle. So if anything which does not meet the normal criteria of the menstrual cycle, that is considered as the abnormal uterine bleeding. Okay, so what is normal criteria of the menstrual cycle? You can see this picture want to tell you the normal menstrual cycle. So where you see the uterine changes mean endometrial changes where the endometrium grow, and when at the end of the period, so it's shut off which cause the bleeding. Okay, so that is known as the menses. So what is the normal characteristic of the menstrual cycle? So number one is it should be regular and predictable. Okay, so if it's an irregular episode of uterine bleeding. So and if over the 12 month, it is known as metrorrhagia. If it's irregular and also heavy menstrual bleeding, so it is known as the menometrorrhagia. When there is heavy, so it's associated with the sign and symptom and the labs. What is other characteristic of the normal cycle? Cycle length should be 28 days plus or minus 7 days. So if it's less than 24 days, so it is considered as the polymenorrhea. So mean it's a frequent menses and these are short interval menses. Okay. So and if the cycle length is more than 35 days, so it's considered the infrequent, and they are the long interval the menses. So this is known as oligomenorrhea. Okay, and the next character is the cycle duration. When the menses start, when the menses end. So it should be normally 4.5 to 8 days. Okay, so and the monthly blood loss should be 5 to 80 ml. Okay, if the blood loss is more than 80 ml, or it's a prolonged menses mean more than 8 days, so are heavy menses, so these are known as menorrhagia. Okay, so the other term is hypomenorrhea. So mean there is a second or less than 5 ml blood loss or small duration menses mean less than 4.5 days, so this is known as hypomenorrhea. Okay, so the other term used is the contact bleeding. It's bleeding after the intercourse or during the vaginal examination or touching. So this is known as contact bleeding. Okay. So two terms which we mostly use. One is metrorrhagia and the other is the menorrhagia. So do not confuse both terms. Just for mnemonic, 3R mean R. So irregular. So when there is irregular, so it is metrorrhagia. So when the increase men in N, which represent increase. So when the increased menses, or you can say heavy menses, so this is known as menorrhagia. In this picture, you can see the normal cycle 1, 2, 3, 4, and in this picture only 3 minutes. Infrequent or oligomenorrhea, here you can see 5. So polymenorrhea, and if the period is too light, small, in the menses, so this is hypomenorrhea, and if the period is too heavy, so it's a menorrhagia, or lasts for a long period, you can say it is known as the menorrhagia, also long period, or if it's a dysfunctional bleeding, so this is also known as menorrhagia. And if there is absence of the bleeding, so it is known as amenorrhea. So these are different terms associated with the abnormal uterine bleeding. Okay, so let's see the our main target is to understand their etiologies and the management. Okay, for better understanding, just review your HPO axis, mean hypothalamus, pituitary, ovary axis, and here is the endometrium. So what is happening? Hypothalamus release the GnRH, which act on the anterior pituitary, which release the FSH and the LH, and which act on the ovary, and the ovary release the estrogen and the progesterone, and this estrogen and progesterone act on the endometrium, so they different changes in the endometrium. So if you see here in this picture, you can see the FSH LH coming from the anterior pituitary, which act on the ovary. So in the early the first phase, meaning during the follicular phase, before the ovulation, so FSH is dominant, and after the ovulation LH is dominant. Okay, and but the important thing is that the corpus luteum is important. So if there is an ovulation occur, so corpus luteum produce the progesterone, which maintain the second phase of the uterine cycle, or the endometrial changes, or the secretory phase. Okay, so if the progesterone does not release, so what will happen? Estrogen continuously grow the endometrium, so it may rupture and it cause the irregular bleeding. Okay. Figo has classified the abnormal uterine bleeding in 2011, so by a simple mnemonic POM-CAN. So it's actually divided into two groups. One is structural abnormalities, which cause abnormal uterine bleeding. Other is the non-structural, mean dysfunctional uterine bleeding. Okay, so in the structure, the mnemonic is POM. What is POM mean? P represent polyp, A represent adenomyosis, L represent leiomyoma, or you can say fibroid, and M represent malignancy, cervical, vaginal, endometrial, ovarian, any malignancy that can cause the abnormal uterine bleeding. Okay, so a polyp, you know about endometrial polyp, which grow inside here. Okay, adenomyosis is what when the endometrial gland enter into the myometrium. Okay, and the leiomyoma, which is fibroid, which is the smooth muscle tumor, benign tumor, and the malignancy of the ovary, uterus, cervix. So all they can cause the abnormal uterine bleeding. In this cartoon, you can see the different pictures. So here you can see the polyp, so endometrial polyp, cervical polyp, and here is the leiomyoma or fibroid. And here you can see adenomyosis, mean endometrial gland are present in the myometrium, and ovarian tumor. So pelvic inflammation. So these are different etiologies which can lead to the abnormal uterine bleeding. Okay, or you can investigate these structure abnormalities by going through the ultrasound. So if you do not diagnose any of the structure abnormalities, then you go for think of the dysfunctional abnormalities, or you can say the non-structural abnormalities. Okay, so the one is number one is the C represent coin, mnemonic is C represent coagulation disorder, and O represent ovarian disorder, E represent endometrial disorder, I represent heterogenic, and N represent non-specific. In the coagulation disorder, most common cause is the Willy-Brandt factor disease. Okay, and then the ovarian disorder, so there are mostly the ovarian disorder cause anovulation. Okay, so mean there is no over release. So and mostly it is due to PCO, mean the polycystic ovarian syndrome, or if specifically if you see the patient presenting after the puberty or before menopause, so mostly is due to ovarian disorder. Okay, anovulatory problem. Or endometrial disorder, not structure. These are functional due to the hormonal disturbance. Okay, for in the thyroid or in the other disorder which disturb the hormonal imbalance. So that can cause abnormal uterine bleeding. And in the heterogenic, so if someone is taking the contraceptive or hormonal replacement therapy irregularly, and the intrauterine devices, the progesterone agents, so they can cause the abnormal uterine bleeding or the anticoagulants. So and in the non-specific, mean there are other diseases like hypertension, liver disease, thyroid disease, adrenal disease. So they can cause the abnormal uterine bleeding. Okay. Now, as I mentioned, the most common cause on this side in the dysfunctional uterine bleeding is the anovulation. What are the causes of the anovulation? So, of course, it's above the you can say and the endometrium, mean it's associated with the ovary and interior pituitary or hypothalamus. In the hypothalamus, you see if the immature the HPO axis, mean hypothalamus pituitary ovarian axis. it's usually present at the menarche. Okay, due to immature HPO access, that's why she does not ovulate. And the other cause is the prolactinoma, the tumor of the anterior pituitary, so which cause increase the estrogen, but increase estrogen, but there is low level of FSH due to prolactinoma, so that's why low FSH, no ovulation. Okay, and no, because there is FSH is important for the follicular development. Okay, in the stress condition, high level of estrogen, and but the FSH release is less, so that's why it can also cause the anovulation. Okay, so these are different causes of anovulation associated with the HPO axis. Okay, if you look at the ovarian problem, as I mentioned, most common cause is the PCO, polycystic ovarian syndrome, and if there is a premature ovarian insufficiency, there is no ova present in the ovary, so it's exhausted, so it can cause increase the estrogen but no ova, so that's why it can cause abnormal uterine bleeding, or due to in menopause there sometimes due to increase the estrogen level. This estrogen is not associated with the ovary, it associated with the other problem like the thyroid diseases or the obesity, so due to other causes which increase the estrogen, so but there is no ova. Okay, so thyroid, obesity, so these all condition increase estrogen also, which impact increasing the endometrium, so that's why endometrium shed off the abnormally, because for the normal the progesterone should be present. Progesterone do what? Progesterone actually you can see, if you see here, the corpus luteum increasing the progesterone level, so but and progesterone withdrawal cause the regular or the planned the menstruation. If there is no corpus luteum, no ovulation, mean no corpus luteum, so no progesterone, it will cause the irregular bleeding. Okay, so same mechanism is summary here. No corpus luteum, progesterone increase the estrogen but no progesterone, so this cause what? It causes endometrial hyperplasia, which cause the irregular bleeding. What is irregular bleeding? Metrorrhagia. Okay, 3R. But the endometrial hyperplasia, it's an alarming sign, because if the endometrial hyperplasia continues, so it can lead to the endometrial carcinoma. So in the initial stage, so it's without atypia, then you will see there is atypia, nuclear atypia. So in the initial stage without atypia means simply glands are increasing, cysts are increasing. So but in the with atypia, the nuclear changes started, and eventually it lead to endometrial carcinoma. So whenever you see the endometrial hyperplasia finding without atypia or with atypia, so if without atypia, give the progesterone, because it's oppose the estrogen, so that's why it prevent the further endometrial hyperplasia. If it's with atypia, so you can give progesterone if she want to conceive, but if she does not want to conceive, go for estrogen, because with atypia it's a risk of the endometrial carcinoma, and because it's a pre-malignant condition, so that's why we go for hysterectomy. But if she want to conceive, you can wait and give the at least progesterone. Okay, if the endometrial carcinoma appeared, so of course there is no other option, simply go for total abdominal hysterectomy and also bilateral salpingo oophorectomy. So you should remove the uterus, you should remove the fallopian tube, remove the ovary. Okay, so it's due to endometrial carcinoma. So this was the simplified version of the abnormal uterine bleeding etiology. So how you should approach the abnormal uterine bleeding? So first of all, take the history to find out the etiology. First of all, you should check the age, because there are different etiology associated with the age. So we will see later. And then next question is marriage. So because sometimes sexual abuse or other problem, they can cause the abnormal uterine bleeding. And the next question would be the marriage. So if she is married or not. So because sometimes they may present with the sexual abuse or any other trauma. So you should ask about the marriage and also take the detailed history of bleeding. So what kind of the bleeding and what is the quantity of the bleeding, the amount of bleeding and the normal cycle of the bleeding and what is happening in the recent, especially in the of the history. Take the of the history if he undergo ectopic pregnancy or the mole. So you should take the of the history as well. Okay, and also take history of contraceptive, because contraceptive, you know better, they can cause the abnormal uterine bleeding, especially dysfunctional type. Okay, and also ask about the other diseases like hypertension or the liver disease, thyroid disease, adrenal disease. So you should ask about these problems. Okay, and in the clinical examination, what do you want to see? So first of all, you should check the general sign like anemia or the other disease in like thyroid disorder symptoms, or the jaundice which represent the liver. So you should check these the features. Abdominal examination, where you want to see the pregnancy or swelling which may represent maybe a mass or a cyst, anything you can palpate. Okay, and then you go for the pervaginal examination. You should rule out the local cause. Anything with the fibroid, polyp, or whatever you see in the pervaginal examination, you should note. And also plus or minus, you can go for rectal examination, although it's mostly not done, but it's helpful if you do, because sometimes due to the rectal hemorrhoid polyps, or sometimes due to urethral, she can bleed. Okay, in the diagnosis, so what investigation you do? Of course, first of all, you should check the beta hcg to rule out the pregnancy, and cbc to check the anemia level, and the coagulation profile to rule out the coagulation disorder, and the hormonal profile like FSH, prolactin, TSH, estrogen, progesterone, testosterone. So this will give the detail of the problem. Okay, and undergo the ultrasound, so abdominal, or you can say vaginal sonography, so where you find the structure abnormalities, and if you want to further investigate, you go for the CT scan or the MRI for the soft tissue. Okay, must do the biopsy if the age is more than 45 years or the bleeding is persistent. So you should do the biopsy to rule out the malignancy. Okay, and in the treatment, of course, treat the etiology, but in the general, you can give the NSAID or correct her anemia, and give the antifibrinolytic hemostatic. But the actual treatment is the medical or surgical treatment of the etiology. Okay, so this is a simplified approach toward the abnormal uterine bleeding.